Hello and welcome to Easy Learning with Dr. Salman Khan. In this video, we begin with the modes of infection. First, the source of infection. The source of infection is food and water contaminated with quadrinucleate cysts. Route: man acquires infection by swallowing food and water contaminated with cysts, and it is through mouth, that is fecal-oral. Vehicle: mature quadrinucleate cyst passed in feces of convalescents and carriers. The cysts can remain viable under moist conditions for about 10 days. Next is the pathogenesis. The incubation period is highly variable. On an average, it ranges from 4 days to 4 months. Infestation by ENTAMOEBA histolytica is called amoebiasis. It is of two types, intestinal and extraintestinal amoebiasis. Amoebiasis can present in different forms and degree of severity depending on the organ affected and the extent of damage caused. Two types of lesions are produced. First is the primary lesions, also called as the intestinal lesions, and second is the secondary lesions, also called as metastatic lesions. Primary or intestinal lesions can be classified under 4 types: amoebic ulcer, amoebic dysentery, chronic inflammation of the intestine, and amoeboma. And the secondary or the metastatic lesions can be classified as hepatic amoebiasis, also called as amoebic hepatitis, amoebic liver abscess, pulmonary amoebiasis, metastatic amoebiasis, which involves the kidneys, the brain, spleen, and the adrenals. Then the cutaneous amoebiasis, and finally genitourinary amoebiasis. First, about the primary or the intestinal lesions, we begin with amoebic ulcer. The trophozoites enter into submucous layers through the crypts of Lieberkühn by penetrating the columnar epithelial cells in the crypts of Lieberkühn in the colon. Cytolysis of the tissue occurs due to lytic activity of the amoebic cysteine proteases like histolysin, cathepsin B, metallocollagenase. Hence the name ENTAMOEBA histolytica. The word histolytica is derived from the enzyme histolysis. There they multiply and continue destruction. Tissue necrosis is also caused by the lysosomal enzymes of the inflammatory cells surrounding the trophozoites and pro-inflammatory cytokines like interleukin 8, also called as IL-8, and tumor necrosis factor alpha or TNF-alpha released from these cells. The necrotic material moves out into the lumen of the intestine, leaving behind an ulcer cavity. In this diagram, we can see the formation of amoebic ulcer. Mucosal penetration by the amoeba produces discrete ulcers with pinhead center and raised edges. Sometimes the invasion remains superficial and heals spontaneously. More often, the amoeba penetrates to submucosal layer and multiplies rapidly, causing lytic necrosis and thus forming an abscess. The abscess breaks down to form an ulcer. Next, the characteristics of an amoebic ulcer. First, we see the macroscopic appearance. The ulcers are visible from mucosal surface. They appear as small nodular swellings. Size is pinpoint to 1 inch in diameter. The shape is oval or round and flask shape on cross section. The typical amoebic ulcer is flask-shaped in cross-section, with mouth and neck being narrow and the base large and rounded. When incised, yellowish-brown colored fluid comes out, leaving behind ulcer cavity. Multiple ulcers may coalesce to form large necrotic lesions with ragged and undermined edges and are covered with brownish slough. Base is formed by the muscular coat. Amoebic ulcer is the typical lesion seen in intestinal amoebiasis. The ulcers are multiple and are confined to the colon, being most numerous in the cecum and next in the sigmoidorectal region. The intervening mucous membrane between the ulcers remains healthy. Ulcers appear initially on the mucosa as raised nodules with pouting edges measuring pinhead to 1 inch. They later break down, discharging brownish necrotic material containing large number of trophozoites. Location of the ulcers: it is classified as generalized and localized. The ulcers generally do not extend deeper than the submucosal layer, but amoebae spread laterally in the submucosa, causing extensive undermining and patchy mucosal loss. Amoebae are seen at the periphery of the lesions and extending into the surrounding healthy tissues. Occasionally, the ulcers may involve the muscular and serous coats of the colon, causing perforation and peritonitis. Blood vessel erosion may cause hemorrhage. The superficial lesions generally heal without scarring, but the deep ulcers form form scars which may lead to strictures or partial obstruction and thickening of the gut wall. Difference between the superficial and deep ulcers. Extension. Superficial ulcers do not extend beyond the muscularis layer, whereas deep ulcers extend beyond, causing perforation, giving rise to complications like peritonitis, hemorrhage, and intestinal obstruction. Then healing. Superficial ulcers heal by re-epithelialization, whereas deep ulcers heal by fibrosis, giving rise to scar formation. Next, the microscopic appearance of amoebic ulcer. It has two zones. First is the central zone, which shows necrosed material but no trophozoite, and the peripheral zone, which shows dead tissue along with the trophozoite. Next, about the amoebic dysentery. It occurs when the parasite invades the intestinal wall and ulcer develops. So amoebic dysentery in a way is a sequel to amoebic ulcer. The symptoms of amoebic dysentery are moderate to profuse diarrhea containing blood and mucus and severe abdominal pain. There also develops a condition which is called as amoebic colitis, which is nothing but chronic amoebic dysentery. In this we see intermittent diarrhea over a long period of time, and it can be often misdiagnosed as ulcerative colitis or irritable bowel syndrome, or commonly called as IBS. Next is the differences between amoebic dysentery and bacillary dysentery. Clinical features. The onset in amoebic dysentery is gradual, whereas in bacillary dysentery it is acute. In amoebic dysentery, fever and vomiting is absent, whereas in bacillary dysentery, there is fever and usually vomiting also is present. Toxicity is absent in amoebic dysentery, whereas it is present in bacillary dysentery. Abdominal tenderness is localized in amoebic dysentery, whereas it is generalized in case of bacillary dysentery. And tenesmus is absent in case of amoebic dysentery, present in case of bacillary dysentery. Then regarding the feces, amoebic dysentery presents with 6 to 8 motions per day, whereas in case of bacillary dysentery, we see more than 10 motions per day. The amount is relatively copious in case of amoebic dysentery, whereas it is small in case of bacillary dysentery. The odor of the feces is offensive in amoebic dysentery, and the feces is odorless in bacillary dysentery. The color of the feces is dark red in amoebic dysentery due to altered blood, and bright red in bacillary dysentery due to fresh blood. The nature of feces, blood and mucus is mixed with feces in amoebic dysentery, whereas in bacillary dysentery there is blood and mucus with little or no feces. And reaction, the stool is acidic in case of amoebic dysentery, whereas it is alkaline in case of bacillary dysentery. Consistency, in amoebic dysentery, the fluid mucus is not adherent to the container, whereas in bacillary dysentery, the viscid mucus is adherent to the bottom of the container. Next, the microscopic appearance of feces. We see the presence of RBCs in amoebic dysentery, which are in clumps and reddish yellow in color, whereas in bacillary dysentery they are in discrete or in Rolex formation with bright red color. Pus cells are scanty in amoebic dysentery, whereas they are numerous in bacillary dysentery. Macrophages very few in amoebic dysentery, whereas large and numerous with containing RBCs in case of bacillary dysentery. Eosinophils are present in amoebic dysentery and scarce in bacillary dysentery. Ghost cells are nil in amoebic dysentery and numerous in bacillary dysentery. Trophozoite. The trophozoite of ENTAMOEBA histolytica is present in amoebic dysentery, whereas it is absent in bacillary dysentery. There is presence of Charcot Leyden crystals in amoebic dysentery, absence in bacillary dysentery, and the motile bacteria are present in amoebic dysentery and absent in bacillary dysentery. Next, amoebema. With repeated ulcer formation and repeated fibrosis, a hard mass of granulation tissue is formed in the large intestine, which is called as amoebema. This does not produce any symptom, but on palpation it appears as a hard swelling. This amoebic granuloma or amoebema may be mistaken for a malignant tumor. Amoebemas are most frequent at the cecum and rectosigmoid junction. So these are about the primary or intestinal lesions. Next is the secondary or metastatic lesions. Hepatic amoebiasis, also called as amoebic hepatitis. Hepatic involvement is the most common extraintestinal complication of amoebiasis. Although trophozoites reach the liver in most cases of amoebic dysentery, only in a small proportion do they manage to lodge and multiply there. Several patients with amoebic colitis develop an enlarged tender liver without detectable impairment of liver function or fever. This acute hepatic involvement is amoebic hepatitis and may be due to repeated invasion by amoebae from an active colonic infection or to toxic substances from the colon reaching the liver. It is probable that liver damage may not be caused directly by the amoebae, but by lysosomal enzyme-lysed polymorphonuclear neutrophils and monocytes and cytokines from the inflammatory cells surrounding the trophozoites. Next, amoebic liver abscess. The parasites accidentally enter the portal circulation where they multiply and continue destruction. During this process, the parasites or the dead material block the supplying blood vessel, leading to ischemia. The necrosed material becomes liquefied and enclosed in a cavity. Hence, it is called as amoebic liver abscess. The process of abscess formation is non-suppurative. Next, this is the macroscopic appearance of amoebic liver abscess. The number of abscesses formed are multiple or more often solitary. The cavity of the abscess location is the posterior superior aspect of the right lobe of the liver. The appearance is ragged and shows shreds of connective tissue. The floor of the cavity shows necrosed material. The content of the abscess is in the center of the abscess containing anchovy sauce pus, which is liquefied necrotic liver tissue. Next, the microscopic appearance of amoebic liver abscess. The abscess shows three zones. First is the central zone, which consists of necrosed dead material. Then the mid zone, which contains disintegrated hepatocytes and necrosed material. And lastly, the peripheral zone, which shows healthy liver tissue and trophozoites. The clinical features of amoebic liver abscess. Fever is present in most cases. Anorexia, nausea, weight loss and fatigue may also be present. Pain in right hypochondrium is present due to stretching of liver capsule. Then the signs are jaundice and diminished respiration on the right side due to hepatomegaly. Then the clinical investigations for amoebic liver abscess. About 3/4 cases of amoebic liver abscess have leukocytosis, that is more than 10,000 WBCs per microliter of blood, and increased serum transaminases. Jaundice develops only when lesions are multiple or when they press on the biliary tract. Untreated abscesses tend to rupture into the adjacent tissues through the diaphragm into the lung or pleural cavity, pericardium, peritoneal cavity, stomach, intestine or inferior vena cava, or externally through abdominal wall and skin. Amoebic liver abscess is 10 times more frequent in adults than in children and 3 times more frequent in males than in females. Next, pulmonary amoebiasis. Very rarely, primary amoebiasis of the lung may occur by direct hematogenous spread from the colon bypassing the liver, but it most often follows extension of hepatic abscess through the diaphragm, and therefore the lower part of the right lung is the usual area affected. Hepatobronchial fistula usually results with expectoration of chocolate brown sputum. Amoebic empyema develops less often. Clinical features, the symptoms. The patient presents with severe pleuritic chest pain, dyspnea and non-productive cough. Next, the metastatic amoebiasis. Involvement of distant organs is by hematogenous spread and through lymphatics. Abscesses in kidney, brain, spleen and adrenals have been noticed. Spread to brain leads to severe destruction of brain tissue and is fatal. Next, the cutaneous amoebiasis. It occurs by direct extension around anus, colostomy site or discharging sinuses from amoebic abscesses. Extensive gangrenous destruction of the skin occurs. The lesion may be mistaken for condyloma or epithelioma. Then the genitourinary amoebiasis. The prepuce and glands are affected in penile amoebiasis, which is acquired through anal intercourse. Similar lesions in females may occur on vulva, vagina or cervix by spread from perineum. The destructive ulcerative lesions resemble carcinoma. So these are the secondary or metastatic lesions. If you wish to see more of such videos, do comment below. And don't forget to like, share and subscribe to my channel. Also, press the bell icon for early notification of my new videos.